Good afternoon, all of our viewers in North America, and good whatever time of day it is to those of us who are joining from around the world. My name is Debbie Shatzkes. I am the very proud first past president of the ASHNR, and it is my absolute pleasure to welcome you all to the second in our series of educational webinars called Talking Heads and Necks. I do have to thank our wonderful Education Committee Chair, Dr. Christine Glastonbury, for starting this and developing this wonderful program. And I'd also like to take this opportunity to thank Erica Cruz, who's providing technical support from the ASNR. So welcome all, and next slide, Erica, please. So this series is going to bring us all to our annual meeting, and for the first time, it is going to be a virtual meeting held in September. If you've never attended the ASHNR live meeting, it is, I think, one of the premier medical meetings in the world, and I say that without bias, okay, maybe with some bias, but we anticipate that this virtual meeting will have the same wonderful educational content and scientific content as well. So you can do a screenshot of this and grab the URL or even use the barcode to submit your abstract to our meeting, and we hope to see many of them so that we can have our usual scientific content as well. Next slide. This webinar is offered with CME, and that is through the ASNR's Education Connection portal. So you can visit the URL listed on the screen and claim CME credit for this offering. Next slide. Next slide, please. Ah, it's there. Sorry about that. Go back, please. Yes, so learning objectives are as listed. None of the participants have anything to disclose, and now actually the next slide. So with that, it is my great pleasure to first introduce my fellow moderator, Caroline Robson. She is the current president of the ASHNR. She is a wonderful head and neck radiologist, a pediatric head and neck radiologist from Boston Children's. And she will formally introduce our speaker who really needs no introduction, the man, the myth, the legend, Dr. Hugh Curtin, and he's going to talk to you about conductive hearing loss. Callie.
Thank you so much, Debbie. Good afternoon, good evening, good morning to all of our participants. I am absolutely thrilled and deeply honored to welcome our speaker this afternoon, Hugh Curtin, who is a radiologist who specializes in head and neck and skull-based imaging. Hugh is an exceptional human being, an outstanding educator, and a wonderful mentor to so many of us. Hugh was born and raised in Canton, New York, and attended St. Michael's College at the University of Toronto. He graduated from Upstate Medical University in Syracuse and trained as a radiology resident at the University of Pittsburgh. After a year in Gothenburg, Sweden, learning pediatric radiology and angiography, Hugh returned to Pittsburgh, where he began doing head and neck radiology and became the chief of the new radiology department at the Pittsburgh Eye and Ear Hospital. Hugh also went to study in Paris with Dr. Jacqueline Vignaud, one of the world's leaders in temporal bone imaging. And then back in Pittsburgh, Hugh worked closely with otolaryngologists and skull-based surgeons and credits his interactions with Dr. Eugene Myers and Dr. Jonas Johnson with helping him learn head and neck imaging. As the Center for Cranial-Based Surgery opened, it brought Drs. Ivo Jarnica and Laligam Sekar to Pittsburgh with further opportunities for imaging exploration of the skull base. And Hugh is one of the founding members of the North American Skull Base Society. We were lucky enough that Hugh moved to Boston in 1995 to become chair of radiology at the Mass Eye and Ear Infirmary, where he has worked for 25 years, has been a mentor, a friend, and colleague to so many of us, and where he is Professor of Radiology at Harvard Medical School. Hugh has served on the editorial boards of several journals and was the first head and neck editor for the ASHNR. He has authored or co-authored over 200 peer-reviewed papers and numerous textbook chapters, and much of his effort has focused on the publication of the textbook that so many of us have used, entitled Head and Neck Imaging, together with his colleague and long-term friend, Dr. Peter Som. Not surprisingly, Hugh has been the recipient of numerous honors and awards, and included amongst these are the Gold Medal of the American Society of Head and Neck Radiology and the Presidential Citation of the American Academy of Otolaryngology, Head and Neck Surgery. Hugh has served also as the president of the ASHNR, as well as of the North American Skull-Base Society. And amongst his achievements, Hugh is most particularly proud of having received the Teacher of the Year Award from the Mass General Radiology residents and also from the Otolaryngology residents of Harvard Medical School. He has also been honored as Distinguished Alumnus by Upstate Medical University. So I give you Hugh Curtin.
Right. Hello, everybody, and welcome to this next edition of the ASHNR webinars. This one is going to be on imaging of conductive hearing loss and our particular approach to imaging for conductive hearing loss. A lot of it's going to depend on what they can see through the tympanic membrane. We'll start out with a little bit of anatomy, emphasizing some of the key structures, and then we'll get right into it. So here we go.
So here are the objectives. I'm not going to go through all of them, but they are available. I have no disclosures. So conductive hearing loss results when there is a problem with sound energy reaching the hair cells of the inner ear. So again, we start to have a little bit of anatomy, and then we're going to focus in a little bit more on the imaging. But anything that will block hearing coming into the ear, making it all the way out to the hair cells somewhere here in the cochlea, is going to give you a conductive hearing loss. So it isn't just the middle ear, external ear, but anything that will block the acoustic transmission as it comes through will give you a conductive hearing loss. So here we have keratosis obturans, partially drained, and that would give a conductive hearing loss. We're not going to emphasize the external canal quite as much, simply because they can look in, make the diagnosis. Certainly we're relevant in staging and evaluating, but this may be a little bit less so. We're going to focus more on the middle ear and some of the things around the oval window and deeper. But we need to know where the actual change is from conductive to a neurosensory. Now, it happens in the hair cells, and these are the hair cells right up through here, and basically the change happens right at these particular cells. You see these little projections up in here. Well, if the tectorial membrane will jiggle these projections, that creates some sort of depolarization, and you get sound, which is then transmitted along the nerves to something more centrally. So where are these hair cells? Just to get things into perspective, we're going to start out with an image, or really a histologic slide of the cochlea. You have the cochlear nerve, one of the vestibular nerves, and here's the modiolus. Here is Reisner's membrane. And way down here, the hair cells are going to live somewhere along here. We have the osseous spiral lamina, we have the basilar membrane, and right in here is going to be the organ of Corti, very small. Now if we blow this up, it'll look like this. Here we've got Reisner's membrane, here we have the tectoral membrane, here we've got the organ of Corti, somewhere down in here. And again, the basilar membrane. If we move this over, so you can see, just to put it in perspective from a size position, this is really getting down into the microscopic level. Now, from here, when you stimulate the hair cells, the impulse changes. Already there's going to be a neural connection to the spiral ganglion and then centrally. So here, if we blow this up, you have the hair cells, and here you've got the connections going more centrally, right in through here. Here goes to the spiral ganglion. Here, by the way, this is what gets stimulated really more so or predominantly when you put in a cochlear implant. You're going to be looking at this particular area, and then again along the cochlear nerve. So, how about this anatomy? Anytime we talk about the temporal bone, or anytime I talk about the temporal bone, I go back to this diagram, which is from Dr. Jacqueline Vigneault. And here you have the petrous apex, the carotid, the jugular. You have the inner ear, semicircular canals, the cochlea, malleus, incus, external canal. And so here is the middle ear. Today we're going to focus really on this region. So if we put the facial nerve in so that you can look through it a little bit, here you can see, and so it gives you the relationships of some of these structures, particularly right in this area where the stapes is going to meet the oval window, and then some things that are close to it. Out here is where you're going to see cholesteatomas, so you're going to put at risk the semicircular canal and a few other things. But again, starting with the anatomy is always, I think, the best way to get going. And this is the simplified view. If you know this anatomy, you know most of the anatomy. Now, we scan the patients in a routine way, try to miss the eyes and the teeth. And then really the technologists will find a sagittal plane image through the lateral canal, draw a line, and now we have a standardized set of axial images perpendicular to that, the coronal images. Having a standardized set of images, I think, is really very helpful in trying to learn this very complex anatomy. Why? Because if you just change it maybe 5 degrees, the anatomy is going to look a whole lot different. So if you're going to look at a lot of these, even if you just do one a week, knowing the anatomy or seeing the anatomy over and over again, it's going to be helpful to have a standardized group. So these are the 5 index axial images. And again, we have them just right along to tell if you're in the right plane. Here is the lateral semicircular canal, vestibule. You go down a little bit lower. Here is the second one, is where the facial nerve goes through the middle ear. You can see malleus, incus, vestibule, IAC, lateral wall of the attic. Cholesteatoma tends to happen here. So these landmarks are obviously important. Over at this level, you have the footplate of the stapes. Otosclerosis begins right up here. Now here you can see the modiolus and the interscalar septum, little slip of bone, important in congenital anomaly analysis, not so much for our talk today. Here you have the round window niche, and then lower down the carotid plate and the jugular plate, because again these will be important when we're analyzing the red masses that are behind the tympanic membrane. But again, all of the anatomy is important, particularly the facial nerve, which winds all the way through the temporal bone. And you can see it starting at the IAC, going to the first genu, going through the middle ear, past the ossicles, over the footplate of the stapes, and then to the second genu, where it takes a second turn, heads down through the mastoid segment. So again, all of the anatomy is important, but these 5 images really give you the key landmarks. While we're here, this is an axial plane. I'll show you the coronal plane in just a minute, but a post-shell plane is actually perpendicular to the axis of the temporal bone. Stenvers also perpendicular but 90 degrees off. We'll use those planes when we're looking for a particular small bony structure. By the way, these images are all labeled up on this website, otopathology.org. You can do a search and find these. Hopefully they will be up to date. So now the coronal plane images, again, similar anatomy, and these are key. Here's the carotid, the cochlea, here's the malleus, incus, and stapes. But this set of images, by the way, this is oval window, this is round window, facial nerve is on just about all of these images. Well, this image right here is probably the most important of all of these coronal images. Right across here. If we blow it up, you can see this important relationship. Lateral semicircular canal, facial nerve, foot plate of the stapes. That's going to come up a whole lot. The surgeons spend a lot of time coming into this area, so we're going to be spending quite a bit of time analyzing this particular region. So, our approach to conductive hearing loss. Our approach to conductive hearing loss is simply this. We'd like to know, we separate it into these three groups. Now, it's not all white mass, but white mass is going to be the introduction, and here is a cholesteatoma, a white mass. And so we're going to evaluate a group of patients that has the white mass, looking for a certain number of landmarks. Now we're going to look at those same landmarks in any kind of a chronic ear, chronic mastoid, but this is the cholesteatoma, and again, the diagnosis is known or highly suspected, and so we're really not asked to make the absolute definition that there is one. The otologist is going to be looking for some other information. What other things might be involved? The red mass, again, very few possibilities, but we'll take an approach to that. And then finally, a conductive loss with a normal tympanic membrane. Well, why is this important? Well, here, if you see a normal tympanic membrane and a conductive hearing loss, a progressive conductive hearing loss, it used to be that they would just operate presuming it's otosclerosis. Well, most of ours get imaging now so that we can try to figure out a little bit more about some of the things that might complicate the issue or might even be the original diagnosis, but we'll see how that goes. All right, we're going to start out with the white mass, and again, there's no question whatsoever about the diagnosis. We like to say that this is the reason, this is not the conclusion. So here is a tympanic membrane, here the little cholesteatoma, which is just a ball full of desquamated keratin that can't quite get out. But that'll be an important thing as well. Here is the cholesteatoma, but intermittently it may drain, so you may have a hole, you may not have a lot of soft tissue, but we're looking for the same things. So the typical findings that everybody seems to know is the scutum and the lateral wall of the attic. Well, here's the lateral wall of the attic, and there's the scutum. Here is the malleus, carotid, cochlea, facial, labyrinthine and tympanic segment. Well, it turns out that this little area, whereas the pars flaccida, is right up in here. And so if you get a little collection up in here, and that's the most typical place to get it, it's going to erode the scutum. Here you can see it's eroded, as is the lateral wall of the attic. But again, they know the diagnosis, so why do imaging? They actually want us to check to see if there's anything that's going to be complicated with this. And the three that we tend to emphasize are the lateral semicircular canal, which I'll show you in a minute, the tegmen or the roof, and then the facial nerve. The scutum is probably going to be going anyway, so it's maybe not so important. But the tegmen, you want to make sure the brain is up where it's supposed to be. Facial nerve, is that at risk? And the lateral semicircular canals, probably the most typical place for a cholesteatoma to erode the labyrinth, so we ought to be looking at that. So here is a case with erosion of the lateral semicircular canal. So what do we have? Well, let's start with the other side, lateral wall of the attic and scutum. That's great. No soft tissue along the lateral wall of the attic here. Prusac space would be right about down in here. But on this side, you have opacification. You have loss of ossicles, but you have loss of the scutum, lateral wall of the attic, and you have erosion of the lateral semicircular canal. Here you can see that erosion. Now, as the surgeon comes in this way, remember the cholesteatoma is going this way, surgeons come in this way, so they are coming from the back side of this. If they tear this out a little bit too abruptly, you may end up with a dead ear. We don't want that to happen. So you look for erosion of the lateral canal. So tegmen, lateral canal, and facial nerve. Now with cholesteatomas, it turns out the tegmen is actually thick. You have a smaller, less well-developed mastoid air cell system, but not always, and so we look for the tegmen. It may be eroded, and they may have to address that when they're doing the surgery. So, scutum and lateral wall, this is the typical cholesteatoma. Scutum's gone, and here, if you look in the axial plane, you can see erosion going out. That's not normal. That isn't the way. I'll show you the normal in a second, but this is not the way it's supposed to look in the axial plane. This is a cholesteatoma. It's almost nice and round, smooth margin, and here you can see it. But if you go through, it's not looking like it's going to the lateral canal. Tegmen looks okay. Facial nerve looks separable. But what about this case? Well, this case over here, no soft tissue, but the scutum is gone, and you have this sort of a cup-like defect, if you will, right lateral to the ossicles. Well, it shouldn't be that way, but there's no soft tissue. So is this going to be a cholesteatoma? Well, this goes on. Now, we were used to saying that there is erosion of these different things, and you get conductive hearing loss. But the other thing, if you talk to people that have cholesteatomas, you usually will have them drain occasionally. So they'll wake up with debris coming out of their ear. So many times this cholesteatoma, like so, can break out of its wall and just evacuate into the external canal. And that's what we think we had happen in this. Here, maybe even you can see the wall of a cholesteatoma, and that can happen. You can have drainage. You get a deep pocket, if you will, but there was probably something there, and it eroded, then it drained. So this is what the normal should look like, lateral wall of the attic and scutum. Here's the tegmen. Again, if you want to look at the tegmen directly, a sagittal plane image is better just because of the obliquity. But here's Kerner's septum, here's the malleus, and here scutum is gone. Here is the space you should generally have between the ossicles and the lateral wall of the attic. And here you have that notch. Again, that is not normal. That is reflective of cholesteatoma. You almost never get such a smooth defect. This is what we think happened. Here was a cholesteatoma. This comes to us through the vagaries of Photoshop. I put this in, but this is what we think happened. Here there was a cholesteatoma, and it drained out into the external canal and leaves this defect. Well, why is that so important? Didn't they just cure themselves? Well, it doesn't matter. From our perspective, we still have to look at the same structures. Even if we're just evaluating this, we don't see a cholesteatoma, we would say that. But the scutum is gone. We think there may have been one. And then you go back to the three important structures, lateral canal, facial nerve, and tegmen. So again, we still have to evaluate them. This has been referred to as an autoadicotomy because the appearance looks very much like the appearance if a surgeon would go in, take out the scutum, and take out a small cholesteatoma. It's called an adicotomy. Well, If it's done by the cholesteatoma, it's called an autoadicotomy. There's also a term automastoidectomy for something that is much bigger, but the autoadicotomy for the small defect right through here. So let's go through this case. This case brings it back together, hopefully. Well, again, you don't see the scutum. But then there's no real soft tissue that they see. They would have seen quite a bit of a retraction pocket. But the key is, the history is that this patient has had drainage from the ear for a number of years. No facial paralysis, no dizziness, nothing else like that. But look at this appearance. This is just not normal. You shouldn't have this nice, smooth wall going all the way around this soft tissue. And here there's thinning over the lateral semicircular canal. Well, what do we think happened? Well, there is a big cholesteatoma, and it intermittently drains. You can see some air right up in through here. So as it drains, well, it was actually the cholesteatoma. It had eroded the tegmen. You can see how thin it is here. It had eroded the tegmen and pushed it up a little bit, and every time it drains, the cholesteatoma comes out, it's no longer supporting, and the tegmen is almost flopping in the breeze, and this can be a major problem. Well, let's go through these coronal images. Here's the facial nerve. We'll look at the lateral canal, and let's follow the tegmen. Well, we go back and the tegmen's almost completely gone, maybe a little fragment, but the thought is that as this cholesteatoma got bigger, maybe it bulged up to about here. Then it drains, and again, no longer supporting, so the tegmen comes down. Here you've got erosion of the facial. Now, very commonly you'll have erosion without having a facial paralysis, but if they go in surgically, the facial nerve is unprotected. Ossicles are eroded, but they're probably going to be taken anyway with a cholesteatoma this size. We go back here, facial nerve comes back in, but the tegmen is still down. Incus is essentially gone. Here, facial nerve. Here's the semicircular canal with it being eroded. But did you follow the tegmen? It's bowing down consistently. So when they go in to take out this cholesteatoma, they need a strategy to support this. They may have to put a little graft to support this so the brain doesn't herniate down. Follow that facial nerve now a little bit further. There's the erosion of the lateral canal. And now we see another defect in the facial nerve canal. So we've got to walk our way through it and find out all these little difficulties so that the surgeon can stay out of trouble. There again, still more erosion, very thin tegmen. Another defect in the facial nerve canal. So the big three, lateral canal, tegmen, and facial nerve. Spend the time looking for those. Make sure there's no defect. All right, now we're going to switch. We're going to go through a different area, and we're going to go away from the white mass to the red mass. And this is what it looks like. This is an aberrant carotid, but these are the possibilities: aberrant carotid, glomus jugulare, and glomus tympanicum. The landmarks are these two. This is the carotid plate, and this is the jugular plate. Those two landmarks should tell us exactly what this is. There's the facial nerve, by the way. So here is the typical aberrant carotid. Now the carotid plate should be right about up in here, just anterior to the cochlea. It shouldn't be coming all the way over to the tympanic membrane. It should stay back here. And so this is right in across here. You can see that indeed this would be right at the tympanic membrane, and this is the very typical aberrant carotid. Here you can see it going across the promontory just in through here. So again, we also look for foramen spinosum. Don't see it here, but it was maybe been somewhere else on one of the other cuts. But that's going to help us with looking for persistent stapedial arteries. That's a little beyond the scope of this talk. So for now, the carotid plate is in the wrong position. That is an aberrant carotid. Can we diagnose this with MR? Sure. Arteriography? Sure. But the anatomy is, I think, the best defined in a CT scan. Now, how about this one? This presented the same way. Red mass behind the tympanic membrane and a conductive hearing loss and pulsatile tinnitus. So lateral canal is totally normal. Here's the facial nerve. We're going through some of the areas that we've already spoken of. Here is where the cholesteatoma would be. Here's the oval window. And we keep going. Everything looks pretty good, but we know they see something red through the tympanic membrane. And remember, we're looking for the carotid plate and the jugular plate. So you follow this down. Here comes the carotid. There's the carotid plate right where it should be. So these images right here have actually completely excluded an aberrant carotid artery. Can't happen. But here's the red mass. Well, what about the jugular plate? Well, it's there, but it's kind of indistinct. This is a glomus jugulare. And the idea is that it's just smudged out. This isn't completely destroyed like in squamous cell, but here's what they see, and here's where they arise. They tend to arise in the lateral plate region of the jugular foramen, and then they can go medially or laterally. Most of them end up in the middle ear, but this is a glomus jugulare because of the demineralization. Very typical. Here you can see it's sort of washed out. Here's what it should look like. It should be pencil thin, but no, it's not. Here, it's essentially gone. They probably will go with an MRI, and you could make the diagnosis probably with this, but I think it's shown better, in my opinion, with the CT. What does the MR show you? Well, it shows you the relationship to the sigmoid sinus. Very importantly, in case they're going to do surgery, they want to know about the opposite side. They want to be able to see where 9, 10, and 11 are going to be sneaking, because if they can spare the more medial part of the jugular vein, then that's a good thing. They won't. They know that the nerves are going to be on the other side of the jugular vein. They're going to be right about in through here. So again, CT, MR, both are going to show you a little bit different things. And now this one. This is one of the first CTs that we did. Well, maybe not the first, but a long time ago. And here, again, red mass, pulsatile tinnitus, and a conductive hearing loss. Well, here's the carotid plate. That's normal. So you've totally excluded an aberrant carotid artery. Here, the jugular, right in through here. The plate looks like it was drawn with a pencil. No erosion, no demineralization. So this is a glomus tympanicum. And this is a much easier thing to deal with than the glomus jugulare. They can take it out through the external canal or through the mastoid, but no skull-base surgery required. And that's why I say these two landmarks, the carotid plate, jugular plate, are the ones to look for when you're talking about a red mass in the middle ear. All right, now one of my favorite topics, the conductive loss with normal tympanic membrane. They look in, there's no red mass down here, no white mass up here in the region of the pars flaccida. This is a normal tympanic membrane. Now, the surgeons will say if you have a conductive hearing loss, particularly if it's progressive in an adult, they think it's number 1, 2, and 3, it's going to be otosclerosis. But there's some things we should look for, and we're going to focus down in this area. Here, this is the region of the footplate of the stapes, and you're going to have the ossicles coming in, so you're focusing on this little region here. So conductive loss, normal tympanic membrane, otosclerosis, and its mimics. Here is the footplate, right about at this level, right in here. So we're going to start there and go through a series of these things that we're going to try to define. This is what otosclerosis looks like. Now, not always. It can be sclerotic or it can be lucent, but most of these are going to be lucent, particularly in people 20s, 30s, 40s, 50s, that sort of thing. But here's the deal. Foot plate of the stapes is there, and you start out in the area just anterior to the foot plate of the stapes. That's where cholesteatoma almost always starts. It does a couple things. It will grow bone, so you'll actually see a bulge coming out like so, and it will be demineralized bone. But if it looks like this, remember the otic capsule, densest bone in the body, and here is where the foot plate of the stapes goes. That's the attachment. Here's the anterior wall of the vestibule. Should be about the same place as the bone just in front of, just beyond the foot plate of the stapes. Here you have encroachment right in through here, and it's demineralized bone. But if you have it looking like this to begin with, the chances are you don't have otosclerosis anywhere else. If you do have otosclerosis here, then you look around the cochlea, because you can have cochlear foci as well. Very uncommon, it happens, but it's rare for you to have demineralization around the cochlea and have normal bone here. In other words, this is the place where you look for the initial focus. And this is what otosclerosis looks like. Here you see this different colored bone. Now usually it's demineralized predominantly, so it's actually softer bone. But this is an elderly patient. Well, no longer a patient. This is from the histology lab. But this is what it looks like, and this is what happens. Here's the anterior or leading wall of the vestibule, and it should come out about like so. This is the cochleariform region right out through here, cochleariform process. But here's the deal. It pushes the stapes backwards. It can fix the anterior part of the stapes, and it also, because of its volume, jams the stapes against the back wall, if you will, of the oval window right through here. So that's what we're going to look for. That's where we're going to start. Now again, this is the most common place. The fistula antifenestrum is really right about in this area, but this is starting really right at the anterior edge of the oval window. Here's the series of things that we look for. Conductive loss, normal TM. Otosclerosis. They will operate whether we see it or not if they have the right history and if we don't find anything else. But again, we start with otosclerosis, try to define the lesion, see how extensive it is, show them the anatomy, and that's one of the first things we do. But then we have to check the round window membrane, the superior canal, look at the ossicles, look at the facial nerve. But again, they will usually, these last two, well, finding the facial nerve and seeing it's in the normal position is always key. But here, they will probably figure this out. Any defect in the ossicles, they'll probably figure out as well. But these things they can't see. So let's start with those, and then we'll touch on some of the things related to the others. So we have to talk a little bit about hydraulics. We always hear about air conduction and bone conduction, but the final pathway of conductive energy getting to the hair cells is actually the fluid transmitting the energy to the region of the hair cells out through the cochlea. Normally you push in the stapes and all of the energy comes into the cochlea and the round window membrane goes out. So oval window in, round window membrane out, and then vice versa. They oscillate synchronously. Nothing goes out through the semicircular canals because it's a closed hydraulic system. There's no real way for you can't compress a liquid, and so you're not going to get any energy going this way. Well, there are two things you can do to interfere with the normal hydraulic conveyance of sound, if you will. One is close off the round window. If you close off the round window, then it acts like a brake. It acts like it's just sealed. And so the stapes will push in, but it'll be very difficult to push in because the round window membrane isn't going out. I think they call this cochlear input impedance. Again, it's a cool term, even if I'm not sure exactly what it means. But the whole idea is that the stapes sees a pressure it's not used to because the fact that you can't move the round window membrane. So less energy, more of it'll just get reflected straight back. It's a hydraulic block, cochlear input impedance. So we're going to look at the round window. The next one is the third window that everybody knows about. When you put in the stapes, round window membrane comes out. Nothing is interfering. These are both normal. But if you put a defect in the superior semicircular canal, now some of the energy can go this direction. We're going to call that a hydraulic leak, and that's going to mean that some of the energy that was supposed to go to the cochlea is going to leak out this way. Conductive hearing loss. That energy is not available to the hair cells out in the cochlea. So let's start with, here we've got a very nice example of otosclerosis, and get used to looking at the coronal images as well. But here, where's the round window? Well, you can see a little otosclerosis there, and here the round window looks like it's blocked. Now, one word of caution. Whenever I talk to the otologists, they say that even if you've got a tiny channel going through this, it may be enough so that the cochlea will work. And again, they're not going to be trying to put a cochlear implant in. This would be a problem with that. They are, if they treat otosclerosis, just going to put a stapes implant in or something like that. So it may still work. But we tell them as much as we can about whether we have air reaching any part of the round window membrane. How much is this involved? Here again, otosclerosis, very typical finding. Here you can see it's completely closed. This is what it should look like. In almost every case now, we can see the round window membrane. There's the basilar turn of the cochlea. Here, round window membrane, round window niche right in through here, and otosclerosis can close that off completely. Here's the round window membrane, just about, well, round window niche right about in here. But here it's closed. Here you can see again the round window membrane right through here. Now here, again, when you push this in, if that's solid, sealed off, you get cochlear input impedance. But again, how much this is going to affect, we're going to have to let the otologist make that decision. And here you can see a congenital anomaly where the high jugular, not just the whole jugular vein, but again, the jugular canal comes up and no air is reaching the round window membrane. So that might give you a conductive hearing loss. So what about the superior semicircular canal dehiscence syndrome? That's an important, well-known abnormality, and this is what it looks like. First of all, we're going to use oblique imaging here. You have something that actually is parallel to the superior canal, and then we'll see the stenvers, which is perpendicular to it. But the superior canal, as I'll show you in a second, should look like a ring in this particular plane. Here's the incus, there's the stapes, facial nerve, and lateral canal. Here you can see the dehiscence. One more image back and you can see how large it is. So what is the issue? Now if you push in the stapes, you have all this hydraulic energy which is transferred into essentially the perilymph. Here's the round window. Here is the defect in the superior semicircular canal. Well, this is not a complete defect. It's covered by dura, but it acts as a third window, third membrane, if you will. And so the energy can escape this way. So you have a hydraulic leak. And that, since the energy is not available to the cochlea anymore, that is going to give you a conductive hearing loss. So round window, and then here is the defect. We're also going to use the Stenvers. The Stenvers plane is perpendicular to the post shell, and here it would be perpendicular to the superior canal, and you can see the large defect. So we'll tell them how much of the circumference is involved, and again, the terminology varies, but how big is the defect? Because it is, well, it's thought to correlate. Here you've got the cochlea, here's the carotid for orientation, the vestibule, here is the round window niche. So again, the Stenvers view, and it will leak out energy, giving you a conductive loss. Here, Tullio's phenomenon you may hear of. You may also get Tullio's phenomenon, which is dizziness when presented with a large or loud noise. What is that doing? Well, normally there should be no motion of any of the liquids or fluids inside the semicircular canals. But if you put a defect up here, then it can leak out energy. You can get motion. So this canal thinks it's spinning, the others don't. The brain gets confused and you get dizzy. So you get vertigo. And so again, that's Tullio's. But the conductive component is something that is really very important. And even if you have otosclerosis, it will interfere with what you can do. Because if you're going to put a stapes prosthesis in, you still may be leaking energy. And again, this may be the explanation. You may not have otosclerosis, as this patient did not. So superior semicircular dehiscent syndrome. So we're going to very briefly talk about the ossicles. Why so briefly? There's a lot that can happen here, but indeed the clinicians, as they come in, will see it almost immediately. So, but we still go through it. You look for heavy calcification or any kind of calcification that would interfere with the ossicular chain vibrating. Here you can see it's filling the oval window. Here you can see some bone deposition. Again, this might have been congenital, likely congenital. You don't have a lot of other inflammatory change. Here again, there's the facial nerve of the oval window, but all that density. So ossicles, any kind of problem, can be something that'll give you a conductive heart. Now here's something, a question we get asked all the time. Here's the malleus, and here is malleus. There's the incus. Here you can see it's right up against the tegmen. Now we'll describe this when we see it, but sometimes it can look like it's completely fused, and yet you still get adequate vibration of the ossicles, and things look fine. Actually, according to Heidi Nakashima, who's a researcher at the Eye and Ear, if you get fusion down at the lower part, it's more likely to give you conductive loss. But they'll be able to tell that just by pushing on the malleus a little bit, and once they get through the tympanic membrane. So we'll describe it, but you don't say, does that mean it's fixed? Because it depends. You can also get just resorption of ossicles, particularly of the incus. So here, this is the normal. Here's the incus. There's the stapes. They should come down and come together. Here you can see the incus. This is a post-shell plane. You can see the incus. There's the stapes right in through there. That looks normal. About this case, well, here, there's the stapes, and here's the malleus. We go back a little bit, and it looks like there's a gap. So this is resorption of the long process of the incus. Now that can be from inflammation, from surgery, or just idiopathic. It's not really well understood. But as you follow this down, malleus and incus, and then you come down, here is the incus, there's the stapes, and they don't connect. Now here, there's the stapes. You've lost the incus. It should go down lower if you can follow it all the way down. And this is what we think is happening. Well, the surgeons don't get mad at us if we miss this, because they can very simply see that once they open the TM. But if you see it, you should mention it, because again, that can give you a complete conductive hearing loss, and therefore they would treat it maybe a little differently than otosclerosis. So mention it. And finally here, this is the thing that we have to look at for every case of temporal bone imaging that we see. The seventh nerve is supposed to be just below the lateral canal and right above the oval window in the normal position. Now, if you have a congenital anomaly, the nerve will start to drift downwards. It will migrate, and the stapes can attach right to it. And so this can be giving you a conductive loss. So always make sure where the facial nerve is to begin with, but then beyond that, make sure it isn't causing the conductive loss. So facial nerve, carotid canal, you look at them in every case you ever see. But the facial nerve canal, in this particular instance, conductive loss with a normal tympanic membrane, you have to make sure that it isn't causing the problem.
Well, that's about it, and thank you for spending the time with us. I hope that's been helpful. I understand there's a little bit of time if there are any questions. And again, this is just one approach. There, I'm sure, are many. This one is really built around trying to emphasize things that are going to keep the otologist out of trouble, perhaps sometimes even more than making the diagnosis. So once again, I hope that this is helpful, and thank you so much for attending.
Hugh, that's absolutely wonderful. As always, a highly educational webinar, and I hope you've been looking at the chat box to the right to see all the compliments coming in throughout your talk. I'd like to hand
you
over.
didn't know I could type that fast.
Type and talk at the same time. It's truly extraordinary. So before we get to the questions, I'd like to ask Deborah Shatzkes to launch her screen with the first of the quiz questions.
All right, hi again, everybody. This is the first of our quiz cases. Kelly has a much more interesting one, but this was posted on Twitter earlier in the week, and we will kind of make a habit of doing that in preparation for these webinars. So keep an eye on our website and ASHNR Society Twitter account to look for these quiz cases. So these are CT images. Oops. Somehow or other, okay. Anyway, here's the answer. So this is an older man who actually presented with a relatively dry ear. He had a big tympanic membrane perforation, but no otorrhea, and the otologist was really not able to see that much going on, but he had a really severe conductive hearing loss. And if we look at this image on the right, this is a coronal image. You can recognize that lateral semicircular canal and the facial nerve canal in its normal position right below it. We should see air in the oval window, but instead we're seeing soft tissue density, and we even get a feeling of some, oops, I'm not sure why this is advancing. I don't know what happened. I apologize. But what was being shown to you was post-inflammatory ossicular fixation. Here is another case, the normal stapes crura sitting at the oval window, no soft tissue density in between. And on the abnormal side, you can see sclerosis of the stapes crura and abnormal soft tissue density interposed, some thickening of the foot plate. So this happens when there is the deposition of fibrous or fibroosseous debris. And what that does is it fixates the ossicles, doesn't allow them to vibrate normally, doesn't allow that transmission into the inner ear structure, so results in conductive hearing loss. And you would typically see, as in these cases, periossicular soft tissue density, and sometimes ossicular sclerosis and even some ossicular erosion. Now, this is pretty classic location. It kind of likes the oval window and the stapes footplate. And, you know, again, clinically, often what you'll hear is that there is a dry ear and the degree of conductive loss really greatly exceeds the degree of observed inflammation. So that's kind of a clinical clue that you may be dealing with post-inflammatory ossicular fixation. Sorry about the snafu with the slides, but back to you, Kelly.
Okay, let's see if I can do this. Okay, share screen. Okay, so the next quiz was of a 10-year-old boy who had a sudden onset of right ear pain and vertigo, and he was found to have a maximal conductive hearing loss. And interestingly, following the sudden onset of his ear pain, a few months later, the patient also had an episode of meningitis. And so these CT images show a curious appearance right in the region of the stapes, where there's a small amount of opacification and the stapes superstructure is not terribly well seen. And then there's a small amount of mineralization which projects into the vestibule. And of course, I'm having the same problem that Dave had, that my slides are going straight to the answer. But anyway, in terms of what was wrong with this patient was that, here we go, let's see if I can get this back. The patient actually had a history of having a bug in his ear. And what had happened was the mother had actually taken the child to the pediatrician, who had irrigated the child's ear. And of course, when the child got home, he said, but I can still feel a bug in my ear. And so the mother took it upon herself to perform some additional interventions. So if we just look carefully at the CT that was performed with that history, as you look here, there is that increased attenuation within the vestibule, which is also then seen on the coronal images. And based on the morphology on the coronal images, we were wondering whether the stapes had actually been somehow pushed into the vestibule. So then as we follow the history, and of course, for this mother, if she had only known, there are actually wonderful instructions on the internet about how to safely remove a bug from a person's ear. And one of the things they say very emphatically is that you can pour all sorts of things into the ear, including oil, but what you should not do is put objects into the ear, especially what this mother elected to put into the ear, which was a wisdom tooth extraction tube, which was a very hard, curved, sort of rigid tube. So the mum tried repeat irrigation using this extraction wisdom tooth irrigation catheter. And at this point, the patient then developed extreme pain, had immediate hearing loss, was noted to have blood from his ear, and had very severe vertigo with nausea and vomiting. So the interesting twist in the story is that a month later, the patient actually developed Haemophilus influenza meningitis in spite of having had the Hib vaccine, which is supposed to be protective. So clinically, the oral surgeon who saw this patient was concerned based on the maximal conductive hearing loss for a perilimb fistula, and he wondered whether the H-flu meningitis had arisen because of a perilimb fistula. But of course, one thing he didn't really expect was what the CT showed, which was migration of the stapes into the actual ear. And so he did perform surgery and found that the stapes were sublux deep into the vestibule and discontinuous with the incus, which was also displaced superiorly. So he very carefully retrieved and pulled back the stapes into its natural position. He used tissue graft to seal around the footplate for any remaining perilimb fistula, used bone cement to fix the incutostapedial articulation, and then performed a cartilage graft tympanoplasty to the perforated eardrum. So I thought that was a pretty unusual case of conductive hearing loss. So now I'd like to look, and perhaps Hugh, if you'd like to help review some of these questions in the question and answer panel. And the first of these is from Nicholas McGlashan, who asks the following question. Destruction of the lung and lenticular process of the incus and poorly pneumatized mastoid and middle ear cleft, completely opacified. Is this typical for CSOM with ossicular erosion? Is it possible to exclude a small cholesteatoma amongst the soft tissue on CT if the clinical information is lacking?
I got part of that. Where is that?
So this is in the separate Q&A question. So he says, you know, if you see a poorly pneumatized mastoid and middle ear space.
Okay.
Yeah?
I got it. So lenticular positive. poorly pneumata, is this typical for, you know, I think that certainly can happen. I mean, we got interested in it in patients that were, and Sawmill Merchant was really very interested in this, that you don't need to have inflammation, that it can actually just, he thought it might have something to do with hyperemia. Apparently the lung process has a pretty good blood supply. You can never completely exclude a cholesteatoma, not even probably at surgery. I mean, they can be tiny, but you know, if you don't see one, you know, the chances are that's not going to be the major issue. So I don't know if any of you want to ask about that, but the you know, poorly developed mastoid in middle ear, well, poorly developed mastoid does go along with cholesteatoma, but I don't think you can make any kind of a correlation with that to suggest that maybe a cholesteatoma had eroded it.
And at that point, sometimes we'll get an MR with resolved diffusion weighted imaging to try and see if there's a cholesteatoma sitting in there. And sometimes we even see cholesteatoma, cholesterol granuloma all mixed up.
Yeah, yeah.
From Felice Darko from Great Ormond Street at Children's Hospital, he asks how to distinguish between a real tegment erosion and a false erosion. In other words, that the bone is normally very thin. And we also had a question on the chat about, similarly, how do you really discriminate true facial nerve canal erosion in these opacified ears?
Okay, both excellent questions, because you can actually normally have actual defects in the tegment. And so that's not necessarily a big, you know, that doesn't mean that they're going to have to do something about it. Very interestingly, well, maybe not that interestingly, but if you have superior canal dehiscence, in a lot of cases, you also have tegment defects that are fairly prominent. As long as it isn't eroded, I think that's what we try to tell them, but you can't really completely exclude it. You can certainly exclude brain herniating down and that sort of thing if there's a question. But we do use Pochel, which is a 45-degree oblique, or a sagittal to make sure that there's air right up against the tegment. But you know, the chances are, I mean, just having a tegment defect doesn't mean that they have to go fix it by any means. But warning them about it, that it's thin, that's probably good enough. The thing about the facial nerve, I actually was, you know, trying to look into this, you know, several years ago, well, more than several, maybe before someone was commenting they were born in 1984. Well, maybe not that long ago. But anyway, so I did look it up, and there are, in the literature, it's anywhere between 18 and 83%, depending on how you measure it. So what does that mean? I think, Callie, you may have been, or maybe it was Deborah, one of you commented that you're really looking for the herniation of the nerve outside. I mean, a defect in the nerve, as long as there isn't soft tissue coming out of it, is not such a big deal. It happens really very, very frequently, and they're used to looking for that. If the nerve herniates out, it can hit the nerve, can give you it can hit the stapes, give you a conductive loss, but usually it doesn't. Usually it's just sort of hanging in there. And then the other point is that, you know, like if you have opacified or partially opacified ear, you're just out of luck. You're not going to be able to see a herniated nerve. You do your best. Now, again, this is something that people explored, you know, a long time ago. And the Pochel plane image is, again, exactly perpendicular to a lot of things. And one of those is the facial nerve in the middle ear. And so if you look at that, that's the one that's going to give you the best hope of being able to see whether it's intact or not, I think.
Okay, thank you. From Dr. Eunice, she says, how does a hydraulic leak cause conductive hearing loss? And do you call it neurogenic as far as it's related to the inner ear? So maybe just a little.
No. It's a hydraulic leak. I mean, we always talk about air conduction of the signal or the emanation get from the foot plate of the stapes to the hair cells. That's still part of conduction, but it is really hydraulic conduction. And so if you leak out any energy in the other direction through a superior canal dehiscence, or interestingly enough, you can get a little definable conductive loss with a big vestibular aqueduct because it'll leak out the hydraulic information. But since it's before the hair cell, it's conductive, not neurosensory.
Okay. From Dr. Casado, can post-inflammatory ossicular fixation coexist with cholesteatoma? How to distinguish between the two?
You don't, I don't think, but it certainly can happen. But I'm not sure that it matters a whole lot, because if you have a big cholesteatoma, that's what they're going to go after. And I would bet if you have a cholesteatoma, there's a very good chance that they're going to end up taking the malleus and incus, and then maybe even part of the stapes. That's where you get into the PORPs and TORPs, the partial and total ossicular replacement prostheses. But certainly you can get fixation post-inflammatory at the same time. Now remember, cholesteatoma is not in and of itself an infection, but is very closely related to it because you can perforate the TM and do all this, that, and the other thing. So I think you certainly can get them to coexist, but I'm not sure that I'm going to be able to, I'm not sure that even without a cholesteatoma, I can ever be absolutely sure that there's fixation. Because as I said, it may look like solid bone, and then the otologist may come back and say, well, I could wiggle the TM, it wasn't fixed. And that's how really, and they'll figure that out as they go along.
Excellent. From Dr. Vijayan, does enhancing soft tissue in the middle ear in a post-surgical MRI without restricted diffusion mean always granulation tissue? Is there any other reason?
Well, I mean, you can get high signal on a cholesterol granuloma, but it can't enhance because that's an iffy term. I mean, we can talk about terminology, but granulation tissue, any inflammation will give you enhancement of the mucosa. Granulation tissue, a lot of our otologists don't like you to use that, but everybody does, and that's sort of some kind of fibro-inflammatory, I don't know how exactly, a vascular, that sort of thing. But I would say definitely you can get enhancement of the mucosa if you have any kind of inflammation. Granulation tissue, they're starting to think that, well, it's a little heavier, but I don't think that's as clearly defined.
Excellent. So lots of compliments coming in the chat box. I hope you're getting to see some of those. Lots of hellos and shout outs from prior trainees from all over the country. And some helpful comments from some of your faculty at Mass Eye as well. Debbie, do you have any other questions that you want to call out?
Who, me or Deborah?
Debbie and Hugh.
Well, one thing is that I have a question for the panelists that Christine picked up on, is I do use the Australian pronunciation of a modialis, because when I was in my training, I was trained by a whole bunch of Australians, and Christine knows many of them. And so I don't know, but the other thing I still to this day don't know is how you pronounce it, whether it's oblique or oblique.
Definitely oblique, but I think the Australian pronunciation is correct. So I mean,
I thought that was
other pronunciation, modialis, modiolus.
Well, that's the other one.
So there's a few people who really make it modiolus or modialis. There's all sorts of great pronunciations, but I really like yours, Hugh.
Okay, all right.
Excellent. Well, thank you all so much for joining us. At one point during this webinar, we had over 500 participants, thank you. We encourage people to become members of the ASHNR if they haven't yet done so, especially our trainees. Remember that I think membership is free for trainees. Anyway, do please join us, and thanks again. We will see you for the next webinar in a week's time.